to you, ma'am. We are live.
So, good evening to all. I extend my warm welcome to all the delegates who are participating in the webinar from the team Unipath. And to talk about the Unipath was started in 2006. We have all the four divisions of diagnostics, starting right from general, rare, reproductive, and oncology, under the able guidance of Dr. Jwalensa sir, our lab director, Dr. Neeraj, lab head, Dr. Firoz, and our VP and head, PMT head, Mr. Dhruv Jyoti. On the Mark of the World Cancer Day, February 4th, this webinar has been conducted. And today our speaker is Dr. Ankur Behel, a senior consultant medical oncologist right from Fortis Gurgaon. Dr. Ankur Behel is a highly skilled cancer specialist who has more than 15 plus years of rich experience in this field. He is an alumnus of Maulana Azad Medical College, Delhi. And from here, he did his MBBS, followed by MD Medicine. He has done his medical oncology from the prestigious AIMS, New Delhi. He has also completed course on adverse drug reactions, drug interactions, and pharmacovigilance at the University of Oxford, UK. Dr. Behel holds clinical expertise in immunotherapy, targeted therapies in combination with chemotherapy, hormonal therapy, supportive and palliative care. He is the lead author of the largest real world Indian data on targeted therapy in head and neck cancer, acute myeloid leukemia treatment, human papillomavirus in the Indian population. He is also the lead founder of various innovative oncology educational platforms, networks, national and international level, evidence-based debates in oncology, live oncology tumor boards, master classes and workshops in oncology. Dr. Behel has joined FMRI Gurgaon from Max Hospital, Shakit, where he was director, medical oncology and hematology oncology. Previously, he was associated with the previous organizations like Rajiv Gandhi Cancer Institute and Research Center and Maulana Azad Medical College. Innumerable publications in international and national journals, books of repute, lead or author of largest world Indian data on targeted therapy in head and neck cancer, acute myeloid leukemia treatment, human papilloma virus trends. So, yeah, so, and this is all to his credits. I am warmly welcoming our speaker of the day, Dr. Ankur Behel, and I would over to Ankur Behel for this speak.
Good evening, everybody. I'm Dr. Ankur Behel. I'm a Senior Director, Medical Oncology at Fortis Cancer Institute, Fortis Gurugram. And I would thank Unipath for discussing and allowing me to discuss this very important topic these days. We are moving to the era of biomarkers testing, and we are moving to the era where after surgery, chemotherapy, there has to be something in maintenance so that our patients in solid cancer get a longer survival as well as the quality of life. So, the importance of homologous repair testing and its clinical implication we have seen across ovarian cancer, prostate cancer, and now it will be coming in some other cancers as well. So, let's study tonight that what is the relevance of HRD testing, when we should do it, at what point we should do it, what are the adequate tissues, what are the adequate platforms, how to evaluate these tests, how to use this test so that our ovarian cancer patients get the maximum benefit. So here we go. So we know that there is a inbuilt DNA repair mechanism in our body, and this faulty DNA repair mechanism leads to the cascade of carcinogenesis. So DNA damage is a constantly occurring phenomena, and the double and single stranded DNA breaks can lead to this genomic instability. And repair of this double and single stranded break is a body immune mechanism to counter these cancer occurrence. So genomic instability is one of the most common underlying aspect of tumorigenesis, and defective DNA repair is bench described as the hallmark of cancer. And to repair these breaks, which happens because of the various external and internal insults to maintain genomic integrity and prevent cell death, a complex network of molecular repair pathway is operational. So homologous repair, recombination repair, is a DNA repair pathway that acts on DNA double strand break and interstrand these cross links. So what happens? What is this deficiency about, and what are the current concept in this pathway? So if there is a deficiency in homologous repair pathway, combination repair pathway, or its genes, it has been associated with several tumor types, which includes breast cancer, ovarian cancer, prostate, and pancreatic cancer. And this has been termed as homologous recombination deficiency, or HRD, which we usually address to it. So tumor with HRD show a higher proportion of genomic or a chromosomal instability, means those patients who have this deficient pathway, their propensity to have a carcinogenesis is increased. So HRR and HRD. So there are homologous. HRR is called as termed as homologous recombination repair. So HRR is essential for an error-free DNA, means there's no all these alterations have been taken care, and it maintains the genomic integrity. HRR fix the double-stranded breaks, which are most genotoxic from the DNA damage. And the BRCA genes are considerately the prototype or the archetypal and well understood component of HRR pathway. So what is HRD, which is homologous recombination deficiency? So HRD is a consequence. It is an after effect of losing HRR capability. When there is a loss of capability of fixing this breaks, whether it's a single stranded or double stranded, then it is called as homologous recombination deficiency, and it is characterized by the genomic instability. So mutations or any epigenetic changes in one or more of this HRR gene can compromise some tumor cells' ability to perform recombinant repair pathway. And cells which have a malfunctioning of HR rely on error-prone pathway, leading to an accumulation of genetic aberration or genomic instability, which we say very commonly. So this phenotype of loss of HRR means loss of homologous recombination repair, and the loss of genomic integrity is called as HRD. So we should be very clear about the terms which are we using, which is HRR or HRD. HRR is homologous recombination repair, and when there is a deficiency, then we label it as HRD deficiency, which leads to a genomic instability in these cancers, which are ovarian, breast, pancreatic, and prostate. So what is HRD? So HRD is a homologous recombination. Status is a complex biomarker that helps identify whether patients can respond to certain treatment, which is platinum-based therapy and various PARP inhibitors like olaparib, niraparib, or rucaparib. So HRD is a predictive biomarker for the treatment of various cancer, and ovarian cancer. We have a lot of papers on that, which says that if you have documented that there is an HRD positivity, so then it is a prognostic marker for both progression-free survival and an overall survival. So HRD pathway and HRD tumors. So when we know that when there is a double-stranded DNA break, so a normal HR repair pathway will restore the normal allele. But if there is a deficient repair, if you are mutated in these genes which are BRCA1 or BRCA2 mutated, so then there is a genome-wide alteration happens, and then we labeled it as an HRD positive tumor, HRD positive tumor, which may be sensitive to platinums as well as PARP inhibitor therapy. So this can happen in a breast cancer when only germline mutation or a somatic mutation, or it can happen in an ovarian cancer. So the presence of homologous recombinant deficiency can make this tumor more sensitive to cisplatin or carboplatin, or we say platinum based therapy, and further as a maintenance with PARP inhibitors, which can be olaparib, rucaparib, niraparib. So PARP inhibitors work via synthetic lethality. You must have read and synthetic lethality many times. You must have countered this term. So it is blocking the base excision repair with PARP inhibitor, which results in accumulation of DNA single-stranded breaks, and this replication fork collapses, resulting in a double-stranded break that cannot be repaired by homologous recombination repair pathway if there is a deficiency and there's a mutation in the genes. So if we see this slide, which is overview of homologous recombination deficiency, so if there's an HRR pathway defect, then there's a deficiency occur and the genomic instability occurs. So this with HRD positivity, the response to platinum-based therapy is increased, and these patients may be predicted to be responsive to PARP inhibitor clinically uh, as a maintenance therapy. So, assessment of homologous recombination deficiency is required when we do a diagnostic workup of these patients. So when we study about HRD, so there are various terminologies which we often use. One is loss of heterozygosity, which is termed as LOH. So it is the loss of heterozygosity present on a single allele. You can see this chromosome. If there's a loss in a single allele, it can be termed as LOH. But when there is a discrepancy in an allele ratio at the end of chromosomal telomere, it is termed as telomere allelic imbalance, TAI, which we say. And at times there is a large scale state transition. State transition points are between the region of abnormal and normal DNA, or between the two regions of abnormality. So if we have these three terminology, which is LOH, loss of heterozygosity, telomeric allele imbalance, TAI, and LST, which is large scale state transition, then we term it as a genomic instability status. So a good test will determine all these components, which is LOH, TAI, and LST, and it helps in calculating the HRD status and determine the crucial genomic event. So a test which is telling us about all these three components and giving us a combined score, that is the best test. So a good HRD testing should give us the information on all these three, and this terminology will be used very often in this presentation. So the importance of HRD testing: 1 in 2 patients with ovarian cancer are HRD. So initially in our practice, we used to do BRCA1 and BRCA2 estimation, and then we moved on to a comprehensive hereditary panels. So, but if we use this HRD deficiency testing, so then we will find that 50% of our ovarian cancer patients will be having a score which is high, and this will be labeled as HRD positive. So it means that 1 out of 2 patients will be beneficial with PARP inhibitor as a maintenance therapy. And by this attempt, we can increase their survival and the relapse rates can be decreased. So 1 in 4 HRD patients have BRCA1/2 mutation. So of all ovarian cancer patients who are HRD positive, 10% only have germline, 15% have somatic. So if we do a comprehensive testing by an HRD as a reflex after testing BRCA1, BRCA2 mutation, so we can clearly say that these patients can have a beneficial survival when we use olaparib or other PARP inhibitors as a maintenance therapy. So these are our NCCN guidelines, which clearly says that in a clinical presentation of an ovarian or a primary peritoneal or fallopian tube cancer, so this we should take a family history and all, and germline and somata BRCA testing should be done in all patients, and HRD status should be obtained so that these patients can further can have a benefit with PARP inhibitors. So this is ESMO 22 guidelines, so which clearly says that the homologous recombinant repair deficiency, HRR deficiency consensus statement, and the level of contributor agreement percentage were very high. So they clearly says that HRR deficiency should be used as a biomarker when we test, when we evaluate these ovarian cancer, fallopian tube, or primary peritoneal malignancy. So biomarkers of HRR deficiency are effective at predictive sensitivity to these inhibitor molecules as a maintenance therapy after first line of chemotherapy for ovarian cancer. And HRR deficiency testing should be carried out at the primary diagnosis. We have a habit of testing them when the patient relapses. So if we do it upfront in all patients of ovarian cancer, then the usage of these therapy in maintenance can lead to delayed relapses or may not be in 20 to 25% of the patients. So, importance of HRD testing by Myred Diagnostic, which is a gold standard, which clearly states that 50% of these ovarian cancer will have HRD positivity. Of this, if we test with only germline BRCA1, BRCA2 testing, then we'll be able to detect around 15 to 20% of the patient. If we combine with somatic BRCA1, BRCA2 mutation with the germline, so we will be able to identify 25% of these patients only, means 1 in 4. But if we test them with an HRD testing, then it increases to 50%. And my choice Myred plus testing identified doubling of these patients as a tumor BRCA testing and 3.5 times as many as germline BRCA testing. So HRD testing, if we have used somatic and germline BRCA testing, we are rates of identification can go up to 22 times, which is 50%, and these patients will certainly get help from the inhibitors molecule. So higher the deficiency, higher the score, and higher chance of response to treatment, and higher the PFS and OS. So we need to determine the score primarily after the surgery, because this is very important that after primary surgery, we have the bulk of tissue, we have tissue blocks with us, and the content of the DNA is higher if we have more blocks, and if we use it upfront, means that we can use the block upfront and less than 1 year of the diagnosis and the fresh blocks, recently made blocks. And if we do the HRD testing, so the chances of getting the higher score and identifying the deficiency are higher. And this is the time where we get the report in 3 to 4 weeks time, and this is the time when we can put our patient to a maintenance PARP inhibitor to achieve a higher PFS and at times OS also. So this is a probability of survival Kaplan-Meier graph, which suggests that a higher HRD score and a lower HRD score in red and blue line respectively, and it gives a higher survival benefit if these PARP inhibitors are given in a maintenance therapy. So this was a data which was generated from 507 samples from the TCGA dataset, for which copy number data and survival information was available. So median OS for samples with high and low HRD score were 1499 and 1163 days respectively, which is correlating with a good p-value. So the timelines for FDA approval for PARP inhibitor, you can see that these molecules were launched in the market in 2014 and 15, and now we have many molecules, olaparib, rucaparib, and at various time site we have identified that if these patients are given maintenance therapy, once they have been documented as HRD positive, who are sensitive to carboplatin, and so by giving this PARP inhibitors in maintenance therapy, increases increase the PFS as well as OS advantage. So women with BRCA-associated ovarian cancer should be offered maintenance therapy with olaparib or niraparib for 2 to 3 years. And these patients with epithelial ovarian cancer, which are high-grade serous, high-grade endometrioid, may be offered these therapies following a complete or a partial response to a platinum-based chemotherapy. However, patients who are treated with bevacizumab concurrent with platinum-based chemotherapy and who have a high-grade serous or an endometrioid cancer may have an olaparib added as a maintenance for up to 2 years following complete or partial response. And women with recurrent diseases who have initially had a platinum-based chemotherapy and have not received a PARP inhibitor initially can be offered a PARP inhibitor maintenance with ola or nira to continue until toxicity or progression when subsequent lines of chemotherapy are used. So the FDA approvals for PARP inhibitors are clear, so that patients who have these HRD positive can be given maintenance. And in recurrent settings, if the patient has responded to platinum-based therapy previously, so then these PARP inhibitors can be used again as a maintenance therapy. So association between HRD status and PFS in ovarian cancer patient, which is with PARP inhibitor, olaparib and niraparib, we have clearly seen that in progression-free survival in HRD status positive patients, which is a blue line, as compared to HRD negative, which is an orange line, clearly says that the Kaplan-Meier curves clearly say that the estimated PFS is higher in patients with HRD positive group. So the key phase 3 studies of PARP inhibitor in frontline ovarian cancer, a very famous trial, the Solo trial and the Prima trial, the Paula 1 trial and the Varial trial, which clearly state that in BRCA mutated group and with HRD as compared to the patient who are BRCA wild type and HRD positive, so the hazard ratio favors that the use of either olaparib alone, which is Saula trial, or a Paula trial with olaparib plus bevacizumab per use. In Prima trial, it was niraparib, and in Valia trial, it was veliparib. All these studies clearly says that the hazard ratio is very low, 0.30 in Solo trial, 0.40 in Prima, 0.31 in Paula 1, and 0.44 in Valia. So all these four trials have clearly shown that these patients who are being given maintenance therapy post the primary treatment has given advantage in the survival. So approach for testing HRD and what are the commercial available tests at this point of time. So we have many platforms, My Choice, Myriad Genetics, Foundation One, CDX, Molecular Intelligence, which is from Caris. We have a Tempus HRD testing, Amoy Diagnostic, and Sophia Genetics. So there are many platforms which study BRCA mutation and GIS, BRCA mutation plus LOH, Molecular Intelligence. Caris looks at BRCA mutation plus LOH. Tempus looks at BRCA mutation LO. So there are various number of genes and the combination of BRCA mutation and testing either GIS or LOH. So Myroid, My Choice Diagnostic use the GIS score, which is a combination of LOH, TIN, and long segment testing. So HRD testing is a germline or a somatic mutation pathway in HRR pathway, or a genomic instability test we call as GIS, which takes into account all three: LOH, TAI. LOH is loss of heterozygosity, TAI is telomeric allelic imbalance, and large scale state transition, which is LST. So Myriad's by choice uses BRCA mutation and the GIS, which is the combination of all three, which is probably the best test. And now with the help of a Unipath specialty laboratory, it's available in India, and we can use this and give benefits to our patients. So as we have said that the commercially available testing for HRD testing, and this is a comparison of the test type, the Myriad Foundation, Strand, and Unipath. So these are so all uses fresh frozen plasma tissue. The I would suggest it's all in the guidelines that the blocks which are 1 year old should be used, who should have more than 200 nanogram of the DNA. The variants type which can be detected in Myriad is BRCA1-2 mutation and genomic instability score, the combination of all three, LOH, TI, and LST, and the cutoff of a value of less than more than or equal to 42 is being taken. In Foundation, they use only BRCA1-2 and LOH with a cutoff of 16. Strand uses BRCA1-2 and genomic scar score with a cutoff of 50. And Unipath use single nucleotide variation, indels, and gene amplification with 28 genes with cutoff more than 0. So we use that, we know that genomic instability markers, all three are being used in Myriad and only LOH in Foundation. Strand uses GSS, which is a different score, more than 50, and Unipath uses G2 score or low pass VGS with AI. So all of them uses next generation sequencing. The TAT, which is it's not that important. TAT is not that important in HRD testing because we need to give it as a maintenance therapy. So if we give the tissue at time, so there's ample of time, at least 4 to 6 months, because we have to use this PARP inhibitor later on. So TAT is 14 working days for myriad and foundation. However, higher for strand and unipath takes 60 days. And if we have to roughly do a direct comparison with the cost, so myriad choice takes around $4,000, foundation cost around $3,400, and strand cost around 90K, and unipath cost around 65K. So this is a very good slide which you can use in your clinical practice, that which test uses what technique, what is the score, and what is the TAT and the cost. So you can take a printout of this slide and keep under your desk. And whenever a new ovarian cancer patient comes to you, you can tell the details to the patient and the party, and you can revise yourself also that what is the cost and what technique they use for the HRD testing. So genomic integrity index score of SOFIA in concordance with the gold standard genomic instability of myriad choice. So this is a comparison where the sensitivity is 93.03. So 93 point patient is an agreement between SOFIA diagnostic HRD solution status with overall percentage agreement with myriad choice. So it's a good score, and they all correlate that with this high percentage they can be used. So, what is the clinical relevance of SOFIA diagnostic HRD solution? And it was demonstrated with a subset of Paula 1 sample, which was 195 patients. So we can see that the median progression-free survival was very high in PARP1 treated patients with HRD status detected by the SOFIA diagnostic HRD solution versus placebo treated, and PFS was non-inferior with SOFIA testing solution compared to the myriad choice. So both the tests have a non-inferior, so we can use so it was 33.3 months with SOFIA and 29.8 months when olaparib and bevacizumab was given as a maintenance therapy. And when placebo plus bevacizumab was given, it was 15.9 versus 15.4 months. So these both SOFIA diagnostic and myriad choice are comparable to each other with a similar PFS outcome with either SOFIA and myriad. So we can see that this progression-free survival probability is similar when we use either of them, either SOFIA or myriad. So how genomic integrity index is calculated and how the sample comes to us and what is the workflow. So we give a fresh frozen plasma, fresh frozen blocks, and there's a library preparation and capture, and the next sequencing NGS data is uploaded, and then with the bioinformatic pipeline and in SOFIA we get a IVID report. And so SOFIA diagnostic solution makes the most of low pass VGS in conjunction with convolutional neural network based deep learning algorithm to produce this genomic integrity index we call as GII. And this score measures the extent of the genomic scarring across the genome as a result of mutation within the gene associated with homologous repair. So it's not about BRCA1, BRCA2, it is about the results of the mutation of the gene associated with this repair pathway, yielding a HRD impact on the tumor samples. So this is SOFIA, one of the reports of from SOFIA HRD solution, the genomic integrity index. So HRD status is called as positive with genomic integrity index of 6.3 in this patient. However, the BRCA status was negative. So 25. So the genes analyzed are 25 HRR genes, which are commonly used HRR pathway genes, which includes AKT, ATM, BRCA1, BRCA2, CHEK1, CHEK2, FGFR3, PALB2, RAD51, RAD51B, 51D, 51C, and 54L. And also it assessed two non-HRR genes, which was TP53 and PIK3CA. A tumor with high GI index above a specific threshold indicates GI positivity and has a low genomic integrity, and a tumor with GI index below the threshold indicates negativity of the GI and a high genomic integrity. So this is a sample report in a patient of a CA ovary post-op post-chemotherapy. However, there are current limitations of this HRD testing. So quantity and quality of the tissue stored in the fresh these blocks are sometimes inadequate. That is why we always say that the sample should be sent less than 1 year of the surgery, and so that the content of the material is good. The tumor There is a tumor evolution events. The factors are dynamically modulating the homologous recombinant pathway, and the drug accumulation could hamper the predictive value of the genomic scar. There can be an intra-tumor heterogeneity, means the cells acquire genomic alteration and they generate spatial and temporal genetic diversity. Tumor area selection from where the sample has been taken, and how much was the necrosis, how much was the inflammatory component, and at times there can be alteration of VUS, the uncertain significance. And some studies have found that there is a high frequency of VUS in HRR genes in ovarian cancer patient, but however, the data here is limited. So a multidisciplinary approach needs to develop and lead on to the precision medicine protocol for HRD testing. So as all patients of ovarian cancer should be dealt in a multidisciplinary tumor board where a surgeon, pathologist, medical oncologist emphasize on again and again about the HRD testing. We are moving from just simple BRCA1, BRCA2 germline testing to an HRD testing, and everybody in the board should know the advantages that 1 in 2 patients will benefit, will be having HRD positive status, and 1 in 2 patients will actually benefit from a maintenance therapy from PARP inhibitor in combination with bevacizumab or alone. So there are various ongoing projects on HRD status globally. From in early 21, we had a phase 1, phase 2, and phase 3 trial to develop a landscape analysis of HR status to identify how HRD is used and define how these HRR calls are made, and a purpose in the language around the use of HRD score. So it's ongoing projects are gone, and but now for last 1 or 2 years we are using HRD as a routine testing in our ovarian cancer patient. So the key takeaways are that HRR is a guardian of genome, and because of its role in repairing double-stranded break with a high fidelity, the assessment of HRD is an important prognostic and predictive biomarker. So it can predict whether the patient will be beneficial in using this PARP inhibitor as a maintenance therapy, so that they have a prolonged DFS and possibly an overall survival advantage. The present work shows that the implementation of HRD testing in a decentral pathological department is feasible, and results are available for most patients for treatment decision in a timely manner. We should not wait for the relapses to happen, rather than give the benefit in the first line, which has attributed to an overall survival advantage also. However, the prerequisite of HRD testing is enough tumor tissue. Yes, more than 200 nanogram of DNA should be done. That's why we say that these blocks should be tested at least 1 year of their when 1 year of their made, means we should not delay it and use it always in the first line setting. The block should be taken early at the first diagnosis of the disease, as it is rather unlikely that enough tumor tissue will be available later after chemotherapy initiation. So, co-testing of HRD and BRCA1/2 germline testing should also aim for an order to enable optimal and timely decision on the maintenance therapy with PARP inhibitors. So, I think with this lecture, the audience and the people who are listening will be more matured of using HRD testing. It should be done. Attempted, all patients of ovarian cancer should get BRCA1, BRCA2 germline testing legally. And you should convince that they should go for an HRD testing if they are BRCA1, BRCA2 negative, and the benefit will go to them. We've seen that olaparib, the PARP inhibitors, are being now cheaper. There are many generics of olaparib in our system. So if we judiciously get this test done and judiciously um, give them maintenance therapy, our ovarian cancer patient will benefit a lot, and they will have a larger progression-free survival and further overall survival. Thank you so much for your patient listening. Over to the organizers. Thank you.
Dr. Pavitra,
Yes.
you can propose vote of thanks.
Yeah. So I hope the webinar has been so much of information to the people, and I would take the privilege to thank the giving the opportunity to organize such a wonderful webinar, and I also thank Dr. Ankur Behel for giving his time to talk about the informations which is very critical in taking the decisions with respect to the diagnostic and the treatment. So I will also thank our all the people who are involved here, and specifically our oncology teams and Dr. Neeraj and Dr. Mr. Dhruv Jyoti for this wonderful opportunity. So thank you for all.
And thank you, online audience. We had more than 200 delegates, 28 here on the Zoom, and rest 166 on online, close to 200. And I must thank Dr. Ankur Bahal for accepting this invitation. And despite his international travel and busy schedule, he has accepted and uh, honored this. Thank you so much.
Thank you all for coming here.